Senior Care and Lifestyle welcomes you to join us for the next 30 minutes, and we promise you a wonderful show this evening. My co-host, Rosemarie Mandart. Welcome, Ro.
Thank you.
And our special guest this evening is Dr. George Fursley. Welcome, Dr. Fursley.
Thank you.
Okay. I'm going to tell you a little bit about Dr. Fursley first. We could have pages and pages and pages of Dr. Fursley's career, but we've kind of squeezed it into one significant paragraph. Dr. Fursley is a professor of surgery at SUNY Health Science Center in Brooklyn since 1999. Dr. Fursley has been the director of laparoscopic surgery at Staten Island University Hospital since 1991 and the director of endosurgery fellowship program both at Staten Island University Hospital and SUNY Health Science Center at Brooklyn. Dr. Fursley is nationally known author, publishing over 100 articles and chapters, and also he has operated and lectured in over 40 cities and countries around the world. And that's very, very concise. We could speak forever, but I'm very happy to have you here with us. Tonight's topic is going to be something that I'm sure many of you have been hearing and maybe experiencing, not only yourself maybe, but your family, but we're going to talk about bariatric surgery. Maybe, Dr. Fursley, we should start with an explanation of, we hear the term morbid obesity. What exactly does that mean?
All right, well, to start with, the strict definition of obesity is an excessive accumulation of body fat. One of the most accepted measurements is the body mass index that a lot of people are familiar with. It's basically the height, I mean the weight in kilogram, divided by the height in meters squared. So a body mass index of 25 is normal. A body mass index between 25 and 30 is overweight. A body mass index over 30 is obese. A body mass index over 40 is morbid obese. About 64.5% currently of American adults are overweight. 5%, which basically represents about 8 to 9 million people currently, are morbidly obese. Now, why morbid? Because, very simply, morbidly obese people die 10 to 15 years earlier than adults of normal weight. They have a 1,200% mortality rate, and more importantly, the reason we say comorbid condition is because they will develop so many associated problems. They are, first of all, stigmatized by the society. They have less opportunity to get jobs. Therefore, they have less productivity. But more importantly, the term morbid obesity that refers to these people basically is associated diabetes, hypertension, respiratory, cardiac. Obviously, we'll cover all these a little bit later on the show. But this is basically the definition is body mass index over 40 or 100 pounds over ideal body weight, which is another acceptable measurement if you want.
Right, that's a measurement I think many people recognize. If you're 100 pounds overweight, you're in trouble.
That's more simple, yeah.
Right. So this evening we're going to talk about the lap banding and a little bit about the bypass.
Okay.
What would you like to talk about first?
All right. I mean, first of all, when the patient, the very first idea is to try not to do surgery, okay, because you want to try the patient to really be under controlled supervision, diet, counseling, exercises. Really, surgery should be the last resort. So if a person has really failed, attempted, and a lot of them, honestly, they do attempt, they do their best, but there's some reason they just can't lose the weight. Then, obviously, you have to do something for them because the surgery is not made for vanity. This surgery is a risky, it's serious, it's commitment, because we're not even talking about vanity here. We're talking about better quality of life. Because for whatever life is giving us, God is giving us, we need to improve the quality of life. Like I said before, no more diabetes, no more cholesterol, no more hypertension, no stroke, no arthritis, no urinary frequency, no menstrual irregularity, pregnancy problems, fertility problems, cancer increase. We need to address all those issues. Now, in the surgical aspect now, when we expose the patient, there's basically two types of operation, like you mentioned, Marianne. We have the restrictive operation, which is basically the banding system. And this banding system is purely to restrict the intake. And this has been introduced actually in 1993 by Dr. Belachou in Belgium. There are over 100,000 bands that have been placed worldwide now. So to give you an idea. It is a silicone adjustable banding system. It is placed around the upper, if you want to hold the stomach. It is placed around the upper part of the stomach to create a small gastric pouch of about 15 cc, in other words, 2 to 4 ounces. This is all that you're going to be able to eat.
Just that much.
The luminal, it has a very narrow outlet. And as you could see, these banding systems have an internal fluid reservoir that can adjust the diameter. As you can see, we can narrow the outlet. If the patient is vomiting, we can deflate it. Let's suppose I put that on a young girl and she wants to get pregnant. I can deflate the band. She can eat during her pregnancy, and then after the pregnancy delivery, we can re-access that through a port percutaneously that will allow us to adjust the band. This is why it's called the adjustable lab banding silicone system. Now, this has been approved by the FDA in June of 2001 in the United States. Obviously, it has been used for the past 10, 15 years in Europe.
Right. I was going to ask you, when did we start doing this?
That was exactly in June, July. There were before several trials in the United States in different centers. Then the FDA approved it in 2001. And now, obviously, surgeons started getting their training, and this is done. So this is one of the methods that we call the gastric restrictive procedure that is done laparoscopically.
Right.
And one of the things is that, if you will hold this again, that we need to explain to the people, this is reversible, because once you put it, obviously if something goes wrong, if a new technique, new modality comes in, you can easily go in and remove it. And after we put it in, we suture the stomach to the upper patch. Why? This will prevent it from slipping.
Right.
And
So
we'll
it
come
can't
to
slip
that
off.
when we discuss the complication.
Right.
This whole tubing, the question is commonly asked, is inside the abdomen. Nothing is outside.
So no one sees anything outside the skin.
And this reservoir, if you want, which is connected, is way under the skin, and the subcutaneous fat is right over the muscle.
Right.
We can get into it with a needle, like I showed you, to tighten the band if we need to.
Right.
Not every person needs adjustment. A lot of patients don't need adjustment because just the band itself with a narrow outlet is enough to make them feel full, not hungry anymore, and they cannot eat. Okay? Some of them need adjustment, of course, because it's loose, their anatomy is, you know, and then they need to have adjustment on and off. Okay? Now, this is done, like I said before, laparoscopically. And what is laparoscopy? Obviously, it's the use of a camera through an instrument. After we insufflate the abdomen, this is one of the what we call trocars in laparoscopy, which allow us to put the camera through an insufflated abdomen. And a typical band operation, we use 4 or 5 of those. 2 that are this large and 3 that are narrower, 5 millimeter. This is what you call 1 millimeter. And as you could see, for example, the other type of operation is a gastric bypass, which I will demonstrate. This is one of the stapling device. Patients say stapling device. If you will hold the stomach.
Sure.
In the bypass, for example, now, it's much more, if you want, drastic than the thing. We go in, and then we create a small patch, which is equal to the patch of the band. And this is the device that is used that staples and divides, as you can see.